Next, we have Dr. Alfia Rasheed. She's presenting on retinal microvascular changes in coronary heart disease patients and OCT angiography-based study.
No. Good morning all. My topic for today is retinal microvascular changes in patients with coronary artery disease and optical coherence tomography angiography based study. So the rationale behind my study is like recurrence risk of an acute event in a CAD patient is 1 in 5 patients. So these are accurately diagnosed with coronary CT angiography and coronary angiography. But we can't always prefer this in a mild symptomatic patient, follow-up patient. So thus we aim to conduct a study about retinal vascular changes through non-invasive OCTA in CAD patients which are treated in different modalities. So the objective of my study is to use a non-invasive opta to study the microvasculature, vessel density and blood flow on the retina in those with CAD and those who do not have CAD, and to determine whether alternation in the ocular vasculature and microcirculation can indicate a coronary heart disease lesion. So the study was conducted in a coronary care center in the Department of Ophthalmology and Cardiology. It was a case control study for a period of 1 year in eyes with the patients who is having CAD and no history of CAD, and sample size were 100 patients. So we included patient who is a non-case of CAD, who is on follow-up, who underwent coronary angiography within last 6 months as the cases, and who is having no history of CAD as the control. Diabetes and hypertension were included. If included, it will be medically controlled patients. And we excluded patient who is having prior history of intraocular surgery, retinal diseases, glaucoma, diabetic retinopathy, and hypertension retinopathy, and media obesity that may hinder the OCTA imaging. So the CAD patient and non-CAD patient underwent a complete ophthalmological evaluation and OCT angiography. In CAD patient, in addition, syntax scoring was done, ejection fraction and serum creatinine was measured. So the syntax score is actually the degree of coronary artery disease and its complexity, and it is categorized as low, intermediate and high. High means the patient is having a complex CAD or more severe CAD. The treatment modalities of CAD patients included medical management, percutaneous transluminal coronary angioplasty and coronary angiography bypass graft. The OCT angiographic parameters which we studied is in the superficial capillary plexus, which included the vessel density, perfusion density and the foveal avascular zone through the ETDRS grids shown below. It is having an inner 3 mm and outer 6 mm circle. And the results came out to be most of the age group were between 50 to 70 years of age group, and the distribution of CAD was like 40% underwent PTCA followed by CABG and medical management. So the relation between syntax score with the OCTA parameters was considered, and we found that the low syntax score, that means less severe CAD, is having better outer vessel density and full vessel density, similarly better perfusion density. But the patient who is having high syntax score, that is more severe CAD, is having a decline in the vessel density and the perfusion density. Similarly, the fast area is well maintained if the patient is having low syntax score or the less severe CAD, and the high syntax score or the more severe CAD is having worsening of the FAZ zone. And we compared the ejection fraction with the OCTA parameters. Most of our patients were having ejection fractions more than 55%, which is normal, and it doesn't had any significant correlating with the OCTA parameters because we had taken treated CAD patients. And serum creatinine also was taken, which was in the normal limit, less than 1.4 milligram per deciliter in most of the patient. Hence we didn't find a correlation with the OCTA parameters and the serum creatinine levels. The comparison between the OCTA parameters with each CAD subgroup and control were studied. It is seen that the medicine group is having decreased value comparing the control group, and PTC and CABG is having similar values, and it is similar to controls also, and these values were statistically significant. So discussion, the CAG and PTCA showed a better retinal OCTA parameters comparing to medically managed people and were similar to control groups. It is recommended by ACC and ESC that PCA-based invasive strategies may improve the long-term survival and circularity compared to a medical-only management. And cardiac severity, which is assessed by the syntax score, showed that the less severe CAD has better vessel density, better perfusion density and FAZ. Wong et al. Actually proposed that the retinal microvasculature is considered as an easily measured surrogate for the coronary circulation. So less severe CAD has a better perfusion maintenance. Compared with the other studies, Song et al. Study in suspected angina showed reduced vessel density in SCP and DCP, and Wong et al. Study in the coronary heart disease showed a reduced flow area and vessel density. IMA study in acute coronary syndrome showed a stronger relationship between the HA risk and the vessel density. So we concluded that the medical management was inferior to PTCA and CABG in treating a CAD patient, and the severity risk score by syntax scoring was linked to the superficial capillary plexus in the OCT angiography. And there is an independent yet statistical association between the each management subgroup of the CAD and the retinal microvascular changes in the OCT angiography. So the limitation of my study was superficial capillary plexus was only studied in my study because our machine was HD OCT 6000 and there is limited sample size. We had not taken any acute event patients and controls were pseudo controls because not taken angiographic proven controls. So recommendation to forecast a current status of the CAD with the normogram including the retinal OCT angiography, clinical features and echocardiography, and if a patient develop new symptoms or worsening of the CAD, we can follow up with the OCT angiography and if needed we can do the invasive procedures later. And further a prospective study should be considered in large sample size in future for more detailed evaluation and prediction of acute events in CADs. These are my references. Thank you.
You suggest Octa in every cardiac patient?
Not every cardiac patient. If he's having any symptoms or mild symptoms or he's having doubtful symptoms, we can consider Octa before doing for the
also
expensive.
this will be used in follow-up.
Yeah, it is better. In my study, it is proved that it is better.
Thank you.